Right, so Councillor Winnington, we're now live.
Okay, thank you very much, Anna. Good afternoon and welcome to the Health, Wellbeing and Social Care Portfolio Decision Meeting. I'm Councillor Matthew Winnington, the Cabinet Member for Health, Wellbeing and Social Care, and I'm chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Until recently, the law stated that all members had to be present in the room to make formal decisions at meetings. However, the law was amended in response to the COVID-19 emergency and councils are able to hold public meetings virtually. This will be in accordance with the local authorities' coronavirus flexibility of local authority meetings regulations 2020 number 392, the regulations. Members of the public are invited to view this meeting and there has been the opportunity for written representations to be submitted. This is a new experience for many participants and we will all need to exercise patience and understanding whilst we familiarise ourselves with the new arrangements. Those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. Members are requested to keep their cameras turned on at all times. Officers are requested to turn their cameras on only when they are presenting their reports or answering questions. If anyone would like to speak, please write their name and RTS request to speak in the chat function. Please access chat from the horizontal menu bar, right click to bring it up, not the icon on the left hand side. Each time you speak, please say who you are so it is clear who is speaking. If there are technical difficulties, we will endeavour to resolve these and where necessary have a brief adjournment, but the meeting can proceed where quorate. I will now explain the running order for this meeting. After apologies for absence, members will declare any interests, then I will receive reports. I would now like to invite those present to introduce themselves. I will read your names out, starting with members. Can you please reply by stating your name and saying present? I will pause for a few seconds between calling each person. Those who are not able to confirm they are present will be recorded as absent from the meeting. So to start with, so can I please ask everyone taking part today to confirm they are present? I call on Councillor Matthew Atkins. Please turn on your microphone and introduce yourself.
Yeah, Councillor Matthew Atkins, Conservative Group Spokesman, present.
Thank you. I call on Councillor Graham Heaney. Please turn on your microphone and introduce yourself.
I'm Councillor Graham Heaney. I'm Labour Group Spokesman on Health and Social Care.
Thank you very much, Graham. And I call on Councillor Jeanette Smith. Please turn on your microphone and introduce yourself.
Councillor Jeanette Smith, and I'm present.
Okay, thank you very much. And for officers, I will ask you to introduce yourself at the start of each report when you are presenting. Other than Anna, as you are our local democracy officer, so if you would just like to introduce yourself, Anna.
Yeah, Anna Martin, local democracy officer. There's apologies from Nhs Richins.
Okay. Were there any other apologies?
I haven't, not aware of any.
Okay, I do have apologies from Helen Atkinson, Director of Public Health. So we have Dominic Latous, who's sitting in for Helen today. Okay, so members, are there any declarations of interest? No, thank you very much.
Yeah, sorry,
Also,
Matt, I've got one,
sorry.
which is my normal one, which is I'm a
Sorry.
paid official of Unison, and therefore, if any Unison business comes up, then I will have to withdraw.
Thank you very much, Jeanette, and apologies for not seeing that. I was become with lots of different screens at that stage, lots of different windows. But thanks for that. Okay, so we now move on to reports. I understand Dominic Latou's is on a clock as well. So what I'm going to propose to do, members, is move the public health reports, which are items 5 and item 6, forwards, so that they can be covered first, and then we will then come back and do items 3 and item 4. So we'll move on to item 5. So that's the Portsmouth COVID-19 intelligence summary. So I believe that's Dom and Matt who are going to take us through this.
Yeah, I think that would be me, Councillor Winnington. So Matthew Gummerson, Strategic Lead for Intelligence, Public Health, Portsmouth. You've all got a copy of the reports in front of you. You have to bear with me. This is my first one of these meetings. Would you prefer that I shared the presentation on screen, or just talk you through the?
Yeah, if you could share the presentation, Matt, because then we've got the people, anyone watching can then see that as you're talking through it.
Bear with me 1 second. Hopefully you should now be able to see my presentation, and it should scroll through to the next slide, which takes you through what I'm going to cover. This is the latest update on COVID-19 related intelligence for Portsmouth. This is based on a presentation that's delivered to the Health Protection Board, which meets weekly, and is then made available on the City Council website on a Friday afternoon. So the data presented in this is the latest data as was available in time for that presentation, so up to last Friday. I can provide verbal updates on more recent data if required. So I'll talk you through the infections for COVID in Portsmouth and also an update on deaths. The caveats we can skip over. Actually, we include these as a kind of front piece on all of our products, but all of the data that I'm presenting to you today is in the public domain, particularly as we're presenting it publicly now. But if you wish to share it with colleagues, do feel free. So the first slide looks at the cumulative rate of infections per 100,000 population. So by looking at the rate per 100,000, it allows a like-for-like comparison with other local authorities. And this is all infections, so Pillar 1 and Pillar 2 infections, as we refer to them, which is tests in hospitals and NHS labs, and also the community tests that are now being undertaken at Tipner and the university and elsewhere, as well as home tests and care home testing. Portsmouth is the dark red line at the bottom. And what you can see is that our rates in Portsmouth remain below our neighbours in Hampshire and the Isle of Wight, and also below the rates for England and London, and largely has plateaued since early June, although we are starting to see a small rise in the cases. And apologies, I just realised a mistake on the chart. It does say per 10,000 in the small text, and it should say per 100,000. What drives those cumulative rates is the new infections that come in that we get data on a daily basis. This chart looks at those new infections and produces a 3-day average for new infections, just to kind of smooth out the lines a little bit. And as of last Friday, we'd had 16 new infections in the previous 7 days, bringing the total up to 558 positive COVID-19 cases since the start of the pandemic. And as you'll see along the bottom there, we are starting to see two or three new cases on a typical day, whereas it had been down at kind of 0 to 1, but still very low numbers compared to the peaks back in April. And also bear in mind that we are looking at cases now coming through in cohorts of people that simply weren't being tested during wave 1. So in order to get a positive test during the kind of first wave of the pandemic, you were really looking at being fairly seriously ill and getting tested in hospital. The cases that are appearing now are predominantly in younger age cohorts, many of them asymptomatic, certainly not experiencing significant health difficulties, and they wouldn't have been getting tested back in March and April. So although we are starting to see a small rise in new cases, bear in mind that context. We do also compare ourselves to our neighbouring local authorities, just to kind of, I guess, make sure that there aren't any emerging issues in the surrounding region. So these spark lines present similarly the course of COVID-19 over the last 6 months, with the blue line being the daily cases and the red line being a 7-day rolling average, just to kind of show you that there's a similar picture across Southampton, Portsmouth, Hampshire and the Isle of Wight, with that kind of plateauing since June, and kind of small increases in little spikes of cases over the last few weeks. But as you can see, numbers in Portsmouth are significantly lower than in Southampton. And obviously Hampshire, much bigger population, has a lot more cases. What we also look at is the 7-day rate. So that tells us what's been happening most recently to give us an indication of whether things are changing. Again, just bear in mind that when this was produced on Friday, Public Health England hadn't updated their surveillance report. So this is based on data up to the 28th of August. And in the case of the map on the left, up to the 23rd of August. But we do have more recent updates to these slides, and they show a broadly similar picture. Portsmouth 7-day rates, time was up to 7 per 100,000. But by way of comparison, we look at some of those areas that are spiking in the country and experiencing local lockdowns or pressures for local lockdowns, and you're looking at rates of 50 per 100,000 and above. And Leicester, at the height of their lockdown, were up at 140 new cases per 100,000 in the previous 7 days. So that's where we are in terms of infections. So in terms of deaths, it's a more positive picture still. So there have been no COVID-related deaths recorded at QA Hospital since the first week of June, as of last Thursday when this chart was put together. And that the COVID-related deaths peaked way back in April. And this is all Portsmouth Hospital Trust deaths, not just Portsmouth City Council boundaries. This chart then looks at just the Portsmouth Local Authority boundaries and looks at all deaths and compares each week this year with average of the years 2014 to 18, the same week in that period. So the purple line that goes across the screen is the average in each week from the previous 5 years. And then the grey bars are the deaths in Portsmouth in the corresponding week, and any purple sections are deaths where COVID is mentioned on the birth certificate, death certificate, sorry. So what you see is that during the kind of peak of wave 1, we were seeing significantly more deaths each week than we would normally see at this time of year. Then over May, June, July, that dropped right down, so we were seeing fewer deaths in a week than we would typically see. And then in the last couple of weeks, for which we've got the data, so the week ending 14th and 21st of August, we saw excess deaths again, with an increase compared to what we have seen in typical years. We would attribute that, it's obviously very hard to know until further down the line, but we attribute that probably to the significant hot weather we had during those weeks, which always leads to excess deaths in the summer, in the same way that cold weather leads to excess deaths in the winter. And we'd expect to see those numbers drop back down to kind of typical weeks or below. So that's all from me. Happy to take any questions, comments.
Thank you very much, Matt. Any questions or comments for Matt at all? No? Okay. Thank you very much, Matt. I think that's very clear again, and I think it's always useful to have those comparisons with our our neighbours and wider afield, which I think, and I think we're seeing, as I think we've seen on the media, that obviously cases are going up everywhere. Well, most of the places in the country, and we're still, though obviously it's up on where we were, and we would like that to stay down. I think the direction of travel is still, we're still very low, and that's a tribute to the work everyone's been doing within the city. I think all our residents, and but it also shows what we need to keep up as well, to keep our rates down. Okay, so thank you very much for that, Matt. So if we'll move on to agenda item 6 then, which is Test and Trace, contact tracing and reservist programme in Portsmouth, all to do with COVID-19 as well. So over to you, Dom, and would you introduce yourself, please?
Thanks, Councillor Winnington. I'm Dominique Latouze, Consultant for Public Health for Portsmouth City Council, standing in today for Helen Atkinson, Director of Public Health. We were asked by Councillor Winnington to give a brief on the work that we've led so far on in public health on the COVID response, and we'll look at the national and organisational changes to PHE, which has been in the news over the last month, look at local plans for contact tracing in local government alongside national test and trace programmes. And then finally, I'll hand over to my colleague Dan Williams, who's going to talk about the voluntary team of reservists, which is going to be set up to aid public health, and the regulatory services team and the emergency planning team with contact tracing. So you've had the paper in the packs. To summarise, first of all, to think about the national organisational changes to Public Health England. At the end of August, 18th of August, it was announced by central government that Public Health England, National Test and Trace programme and the Joint Biosecurity Centre will be brought into a single organisation that will be fully operational and up and running formally by the end of March 2021. It's going to be called the National Institute for Health Protection and brings together a number of the all of the existing functions of those three organisations, so including any responses to infectious disease, but also environmental hazards, the COVID testing programme, intelligence and data on outbreaks, emergency response, all of the research and the reference labs, the specialist epidemiology and surveillance, the kind of things that Matt Gumson's just been taking us through, the existing Centre for Radiation, Chemical and Environmental Hazards, which was a function of Public Health England, and any global health security concerns. So much bigger than the COVID response that's running now. In terms of NHS Test and Trace, you'll be very familiar with this, but to go through the function of that programme, it tests those who are symptomatic and ensures that the contacts of those with symptoms can be followed up. And the point of that is obviously to limit spread of infection. SAGE, the government advisory group, has advised that in order to prevent that spread effectively, we would need to contact 80% of an index case, an initial case, and 80% of those contacts would need to self-isolate. So actually in Portsmouth, as Matt just outlined, we're actually achieving those 80% contact tracing levels, which is excellent. And I don't think we've ever dropped below that 80% or been very close to it. All those who are confirmed by a laboratory test as having COVID are automatically entered onto a national contact tracing advisory service system that then follows through to identify the case and their contacts. And the flow chart of how somebody would move through that process is outlined in the paper. So I will now hand over to Dan Williams. I'm happy to take questions at the end, I think, because it makes sense to have it in the round.
Thanks very much, Dom. Yeah, that sounds sensible. Dan, welcome. Can you introduce yourself, please?
Oh yeah, I'm Daniel Williams. I'm Public Health Development Manager in Public Health, and again standing in for Helen Atkins. And I'm going to take you through the rest of our paper, talking in particular about the local contact tracing initiative that we have, and also building up a team of reservists to help us with answering the requests for advice that we're getting in public health and also in regulatory services. So a locally supported contact tracing system is an initiative to help prevent local areas from entering lockdown and would allow us to take control over case completion rates from the national system, with the aim of increasing that proportion of cases traced through local means and hopefully push it well above the 80% threshold for being successful. This may be particularly necessary if the national test and trace system is under stress, for example, because cases are peaking across the country. Additionally, the advantages are of a locally supported contact tracing system. It gives us a higher potential to track down cases with incorrect or incomplete contact details using our locally held information, and a higher likelihood of cases responding due to the use of local telephone numbers and callback facilities. We have put in a request to Public Health England via the South East Local Authority Directors of Public Health to go ahead with a regional pilot where each local authority will be will lead a locally supported contact tracing system within a regional model and to a standard operating procedure. We're expecting sign-off from Public Health England any day now and have a team of a dozen contact tracers drawn predominantly from Public Health and the Wellbeing Service on standby. There is a flowchart again in your documentation 4.5, which takes you through what would happen in the case of a local contact tracing system effort. And our task at that point will be to trace trace cases rather than contacts. The contacts of those cases will be followed up by the national test and trace system rather than us. So that's one arm of the things that we're doing. The other, under section 5 of the paper, is our reservist programme, where we are setting up a team of voluntary reservists drawn from the rest of the organisation to help public health, regulatory services and EPRR to meet the ongoing challenge of the coronavirus. We see this very much as both a corporate and a public health initiative. We're working at the moment with HR to recruit from across the council, but have looked at the first instance to offer the opportunity to those who've been shielding and unable to return to their substantive roles, and already have keen interest from at least 5 of these employees. We've drafted a job role, and this is about to go out as an all-staff communication in the very near future. We will then start to train those staff and hopefully have them up and running by the start of October to help us out with the rota system in public health. I understand that when HR originally asked for help from the organisation with COVID-19 at the start of the pandemic, there was a very healthy response. So I think we can be confident of recruiting at least that many, 20 people that is, that we're after. Thank you. Any questions for Dom or for me?
Thank you, Dan. Open to members. Any questions or comments? Jeanette.
Yeah, it's on the question for Dan. What happens if you can't trace the person? It says in there about details and then it's handed over after 48 hours. Then what happens?
That's a very good question. I think we would, as the flowchart suggests, pass that to the national test and trace system. I think with the best will in the world, it's going to be a struggle to contact every single case that we're forwarded by the National Test and Trace system, but I'm hopeful that we would be able to add to their efforts with our local initiative.
What is that, Daniel? What would we look at that others haven't got information? What is it? Electoral roll? Is it?
I think we're looking to draw from any of the existing data sets that the council has with the appropriate information sharing agreement in place, and because this is effectively a life or death situation, we will have permission to do that, and being able to tap into those sources may give us a head start over the national system to be able to contact those people.
Right. And how many times in the 24-hour period before it's handed over, or 48-hour, how many times are the person rung?
Again, I think
twice. Or?
That's a difficult question to answer, but I imagine we would try certainly at least twice to get through to someone in that 24-hour period, and depending on the scale of the outbreak and the urgency, we would obviously try again until we get through to someone. My understanding from the national system is that very often they do give up after 2 or 3 attempts, and those are the kinds of calls that might be put forward to us. And it may just be something simple, like they were on that particular day feeling too sick to get to the phone or to answer, and that maybe, you know, by the end of that period they might respond.
Yeah, and they might be like me. If I don't recognise the telephone number, then I don't pick it up. Because I think it's a scam. So. Are they identified or not?
We're talking to IT about how we're going to be presented to a caller on their phone in terms of what will come up, and hopefully we can establish something that will be as the least threatening thing possible, really, I suppose.
Okay, thank you.
So I should add that the 24-hour, the paper says that the 48-hour window is likely to be reduced to 24 hours in the near future. So if National Test and Trace is not able to get in touch with somebody in that first 24-hour window, then it's likely to be passed over to us. And as Daniel said, we wouldn't be following up anybody in using council data without consent and without those proper data sharing agreements being in place. So we're working closely with our data leads in the council to make sure that that's all following due process. In terms of following up people for how many times, I think that's something that we'll need to establish through the pilot scheme and work out. That's one of the advantages of going first, if you like, nationally. We can trial this and work out what's best. And what's worked in other areas really well, for example, in Newham, has been developing really strong community links with community members, so that you can draw on those links with the community, perhaps get in touch with cases where the local authority hasn't been so successful. So that's something that we've got very good relationships with our voluntary community sector and community leaders. That's something we're looking to develop quickly as well.
Thank you both. Graham or Matt, any questions, comments? No? Brilliant. Well, thank you very much. I think that's a really good summary of where we are and understanding that system a bit more. And I think obviously the reservist idea, which I think was an absolutely fantastic innovation, and I think it's one of those things that is really going to really shows about how members of staff across the council are who have been working across portfolios and out of departments the whole time of the pandemic. It really does show and gives that opportunity for that to continue, and it's been really good that it's had the back of both my fellow cabinet members and also the senior staff across the council as well, which I think is really important that buy-in happens, because this is such a critical thing for us as we get into any second peak, and obviously into the colder weather as well. So thank you very much, both of you, for that. So we're now going to move back, colleagues, to agenda item number 3, which is provide respite care to citizens with a learning disability, and that is Andy presenting. And as well as you, Andy, could I also ask Richard Webb to introduce himself at this point as well, in case he needs to come in on either of the social care items. So over to you, Andy and Richard.
Thank you, Chair. Good afternoon, members. My name's Andy Biddle. I'm the Director of Adult Care for Portsmouth City Council, and I'll wait for Richard to introduce himself.
Good afternoon, Richard Webb, Finance Manager for Adult Social Care and Public Health. Back to Andy.
Thank you. So the report before you talks about respite care for citizens of Portsmouth who have a diagnosed learning disability. The recommendations are that we recommence respite at the Russets unit, which is the main place that we provide respite for folk with a learning disability from. That we engage with the 2 people who've expressed a wish to move from Russets, because we have some permanent residents living there as well. That planning is undertaken to consider how long-term accommodation is managed in Russets, and that we consider an options appraisal around respite provision for adults with learning disabilities in the future. In terms of the context, what I've laid out there is how Russets came into being, the fact that it's part of a private finance initiative contract, who it provides respite for, and its date of building, and the fact that we have a management support contract provided via the contractor for the remainder of the contract period, which is up until June 2032. We saw permanent residents come to Russets between 2012 and 15, when we saw a number of properties that were providing care and support close in the city. This was always meant to be a temporary arrangement until other properties could be identified, but we haven't managed to identify the properties in this time frame up to this point. So the reason for bringing this report is to enlighten you that last year we provided 2,058 nights of respite to 53 families, but that the impact of COVID-19 since March of this year has meant that we've only been able to project providing half of that for the remainder of the year, which is why we think that we need to open up the unit and provide respite. I've listed at 4.2 on page 4 in your pack the concerns that we have if we don't provide some kind of respite to families. We don't want people to move into a crisis situation, breach the Care Act, see an increase in complaints, or a potential increase in the cost of placements. I've then detailed, moving from page 4 into page 5, with floor plans of Russets, and laid out where we are at the moment in terms of permanent residents on the first floor and people who use the respite service on the ground floor. And talked about providing respite for a maximum number of people according to the current guidance that we're following in terms of the COVID-19 pandemic. We believe that moving into page 6, if we take up the request of 2 of the permanent residents to move from Russets, we could provide respite for more than 2 people at a time, which would enable us to catch up a little on some of the nights that we've lost for families since COVID pandemic came in March. We have been engaging with those residents, their family and advocates, in between drafting this report and bringing it to you here today. We think that because of the way that we need to do moves, we'd probably be taking till the end of January 2021 to complete them, maybe before then, but we want to give a realistic time frame. And we think we may also face some costs around increasing staffing establishment, because we're not able to fully run our day services at the moment because of social distancing guidance. So what we proposed to do was to bring a further detailed paper to this decision-making meeting, probably toward the end of this financial year, to set out some long-term plans for how we're going to maximise respite even further, but ensure that people had appropriate long-term accommodation to meet their needs. I then touched on the equality impact assessment. We didn't see any adverse impact from this plan. Legal implications, we have our legal colleagues have commented. They've given a however at 6.3, but otherwise don't see any issues legally according to this, and we'll check out that however about the service operating manual. The contractor has collaborated and cooperated with making the adjustments that we needed to make to the physical environment so that we could provide respite safely. And then Richard's made some finance comments there explaining the reason that we may see a temporary increase in the staffing budget in executing this plan. And I'll leave that report there, but happy to take any questions or comments.
Thank you very much, Andy. Any comments or questions from members? Great.
Thank you, Andy. Apologies, I wasn't able to come to the briefing because I was on holiday, so I may be asking a question which is already been well understood the answer for everyone else. Did we have to cancel any respite care for anyone as a result of the COVID crisis? And did we make any alternative arrangements for anyone? That was the case.
We did have to cancel quite a lot of respite during COVID. It was difficult to make respite arrangements for people because we don't have a huge provider market in terms of respite for people with a learning disability. So we maximise the other resource that we have in the city that's provided through the independent sector, and we continue to do so. This was a question that came up at the briefing. I think Councillor Smith had a similar or a question along the same lines. And we continue to do that. What we hope to do is to be able to go out to our market with a clear statement of our respite need and encourage other providers to apply so that we're looking at a range of provision, not just the two that we have at the moment. So families did have to go without respite. What we tried to do in the meantime was to use our staff that we that couldn't work in their standard jobs during COVID to provide some extra support for people living at home with their families. That was mainly through the day service provision, but would have covered people that would normally have come in for respite as well.
Okay. I have one other question about the finances. It talks about the cost that should be charged £1,000 extra on as a temporary cost increase, but I presume, does that depend on how long the COVID crisis goes on for? Because obviously if it continues, we may be spending more than that. So I wasn't sure what the estimate was based on and how we were sort of planning for that. Maybe one of those sort of unanswerable questions, but I just wondered about the background to that figure.
I'm certainly happy to lead off, and I don't know if Richard then wants to come in. So yes, to a certain extent, we are bound by however long we have to make these arrangements, I guess, in terms of the pandemic circulating in society. I think what we would hope to do as part of a mitigation against cost is bring forward increased options for respite so that we weren't focusing all of our eggs in one basket, if you like. But Richard, I don't know if you want to make any further comment.
I think you're absolutely right. I mean, this is an assumption, I think, for the remainder of the year. So should this go on longer, then obviously that cost will increase. It will also depend on the level of clients and the staffing ratio that's required as well. So there are a number of factors that will fluctuate there, but it's an approximation at this time based on what we know. But obviously the cost of that is temporary versus the potential cost of requiring longer term placements if we don't have support in place for certain individuals.
Okay. And just to clarify, when you said the end of the year, do you mean the end of the financial year or the end of the calendar year?
Financial year. Yeah.
Financial year, right? Yeah, okay. Thanks. Well, thanks for that. That's very helpful. Thank you.
Thanks, Graham. Matt.
Oh, sorry, I'm
So you were off mute, Matt, and now you're on mute again. Yeah.
Can you hear me now?
Yes.
Yes. I was just noting that the report mentions these two permanent residents who would like to move out of Russets. Do we have any easy or available accommodation identified for them to move into, and how dependent are the plans on being able to find them alternative accommodation? Because obviously that seems kind of a key element of the the report, but it doesn't say whether or not we've easily got accommodation for them, or if that's going to be quite a challenge to find.
We have some options available. It very much depends if the option suits the individual, and that's a process that we go through an assessment to ensure that all of those care and support needs could be met in the right place. And we then go through a process of ensuring that people had the opportunity to see that environment, become familiar with it, ask any questions that they had, and include their families, which is the reason for the lengthy process. But yes, we do think we've got some options available. But generally speaking, you're absolutely right. It can prevent us doing stuff when we can't identify it. And that hiatus that we've seen between the 2012-15 closures and those people coming into Russet, that's been one of the things that's prevented us moving that on up to this point. If those options weren't to be appropriate, we'd have to rethink what we were doing. And maybe search further afield. But what we always try and do is keep people as within the city boundary, or certainly as close to the city boundary as we can. We try not to place people outside of it.
Thanks very much for that, Andy. Any other questions or comments? No, and as Andy said, I know Jeanette brought us some issues at the briefing, so which has been covered within the report. I think the important thing about this report is that it's effectively a report to do another report, but it has to be done now because we've got this particular issue with the two members, two residents who want to move on, and also it's that direction of travel and fits in with the wider point of making sure that we've got the right provision for people in the city. So I'm very happy to accept the recommendations in full, and obviously looking forward to another report back on some of the work that's being done, which will then take us forward to a longer term plan in January. So thank you very much for that, Richard and Andy. And then we move on to finally agenda item 4, which is the adult social care response to COVID-19. Back to you, Andy.
Thank you. So this is an update to a second update around COVID-19 that we've brought in terms of adult social care. It doesn't cover all of the issues, but it's tried to look at the key issues that we've been dealing with since we last presented in July of this year. So in the context, I've outlined the focus for adult social care nationally in the country. It's driven by 3 quite significant pieces of legislation, as you can see listed there. And so we tend to be governed by guidance that comes out from government and have to work to meet those requirements. I've then talked about the move to business critical activities, which you'll be familiar with in ASC and the rest of the council, and then gradually reintroducing services as the pandemic has abated somewhat. And obviously, what we've done with Russets is part of that, is standing services back up again. Moving on to Schedule 2 of the report, onto page 10 in your pack. We've continued to hold a strategic stock of PPE in the council, and we were very successful in that since March, both in having a senior officer that works to ensure that we've got the right supply and that no provider of social care in the city needs to go without personal protective equipment. And we were pleased to be able to maintain that throughout the more virulent period of the pandemic, and have very positive feedback from our provider market about that. They could come to us when they had issues and we'd make sure they had what they needed. The second part, 2.2, talks about hospital discharge, which has been commented greatly on in the press. So we saw government guidance issued in March that was then updated last month in August. We've seen a very helpful summary that the LJ have produced, which I've included a link for in that report. But in summary, there's an expectation around a certain percentage of people being discharged home, with some of those requiring support, and gradually decreasing percentages depending on the high sort of support environment that's being discussed. There's then some information there about what how the decision is made for people to be discharged around daily ward rounds. And there's a criteria that was come up by one of the Royal Colleges, one of the Royal Medical Colleges, around people's reason to reside in acute hospital and thereafter when they should be discharged. For about half of those people discharged that need support, it's expected that they'll need a period of care and reablement. So what government's done is moved from talking about providing open-ended funding for people discharged from hospital by the NHS to providing a clear 6-week window of funding for people that have rehabilitation and reablement needs. And during that time, an assessment is undertaken, both financial assessment and needs assessment, to understand whether they have continuing social care needs or whether they may have continuing NHS healthcare needs. Talks about testing very clearly, and also where someone is tested in hospital, but either they can't be safely isolated, receive isolated care in their care home, or the test result isn't available, then the local authority is required to maintain a facility where that individual can go and be cared for in isolation. And for us, as you'll be familiar, that's Harry Sopnick House, the Gunwharf unit. I've then talked about the main focus of our activity. So we're looking at the funding that was in place prior to the 1st of September, which, as I said, was open-ended for people being discharged from hospital, and ensuring that we can assess all of those folk and understand their needs, understand if they're in receipt of the right package of care, understand if they're in a care home in particular, whether they need to stay there or whether they can move on, and catch up with all of that work that occurred during the more heightened period of the pandemic. And I've talked there about the plan in preparation to recover that position and to complete those assessments and those financial issues. In terms of care homes, we've seen, as you'll be aware, both nationally and locally, tragic deaths of people in care due to COVID-19. And we saw outbreaks both in Portsmouth City Council owned and managed care homes and in independent owned and managed care homes. What that's enabled or prompted is infection prevention and control advice being made very freely available through NHS colleagues for all care home providers. And we, as of the 20th of August, when I drafted this, we've been COVID-free for residents in our homes for 115 days. We follow very stringent criteria before we make any changes, such as allowing visitors back to visit outside of care homes. Then we check with our public health colleagues and our NHS colleagues and try, as far as possible as we can, to prevent any kind of outbreak reoccurring. I've talked about the Social Care Action Plan and the Infection Control Fund that was passported through local authorities directly to independent care providers, and the returns that we've issued. And then finally, under 2.3, I've talked about continuing to work to provide support to care homes and other providers of social care through regular meetings with them, whatever sector they're in, and also having what we call a provider portal, where we've got an internet site dedicated to briefing them, putting any reports we see out there, any analysis, through either ourselves or the NHS. In terms of financial support, we've been supporting our provider sector through a combination of things. We've started to taper down our minimum income guarantee, which was based on their income pre-COVID, and that will finally cease in October. But we continue to be in regular discussion with our independent sector colleagues and understanding the financial stresses and strains that they have, and feeding those back regionally and nationally where appropriate. I've then talked finally at 2.5 about testing. We know that there was a great deal published about testing and a great deal of commentary on testing, and continues to be so. We have seen the announcement of regular care home testing for both residents and staff. We've seen some real challenges in ensuring that we can get on the care home testing portal, get the kits sent out, get the test back in a reasonable time, the results back in a reasonable time. And the assurance that we've had from Department of Health and Social Care is that this system should have been working fully from yesterday. So we're taking some soundings, as we spoke about this morning with Councillor Wellington, with our provider colleagues and internally, to understand whether we're still seeing those issues or whether we're starting to see a levelling out of those issues and things are coming to a more consistent approach as we've been promised. And that's a summary of C19 responses from July. Happy to take any questions or comments.
Jeanette.
Thank you. Andy, in 2.4, you talked about the MIG ceasing. Is there any anticipation that there might be closures of the independent sector because they won't be able to financially carry on? Or is that just doom and gloom and I should smile a bit?
No, I don't think it's doom and gloom. I think what we've seen both nationally and we've spoken locally is financial fragility in the adult social care sector. We've been talking nationally for 2 to 3 years about a green paper that sets adult social care on a sustainable footing in terms of its funding, and we haven't seen that. We've seen a green paper announced 4 or 5 times and it hasn't then been brought forward. So at the moment, as it stands, we have a collection of relatively short-term grants and monetary provision that's made nationally for social care, but we don't have a sustainable funding picture. And that reflects on the rates that councils are able to pay their independent sector providers and puts the independent sector under strain. We're also seeing a decrease in nursing care placements nationally and regionally since the COVID pandemic. And so that will put the sector under further strain. The advantages that we do have in Portsmouth is we have extremely regular dialogue with all of our independent providers. So we'll see provider representatives minimum on a monthly basis. We'll have Teams meetings like these where there's FAQs put up and members of council staff officers are available to talk to independent sector providers and work with them to understand what their strains are that week, that month, that sort of 6 months. What we've also do is extend an open invitation to people to come to us individually if they don't want to talk into a group and tell us what they're experiencing financially, and then we'll try and tailor our response to that. So I think your assumption is absolutely right. The sector is at quite considerable risk, but I think in Portsmouth we try to have a reasonable handle on it and we try to respond as flexibly as we can do. And the minimum income guarantee has certainly been an example of that. Richard may want to come into that as well.
Yeah, thanks, Andy. I mean, the minimum income guarantee scheme was one part of support that we provided. So we've got the other part, which is providing sort of direct PPE, as Andy's already mentioned. But we also, where they do purchase PPE, we're currently reimbursing them directly for that cost as well. So we're doing a number of things, and this is one part of it. And we're constantly reviewing it and seeing whether we need to put anything in further after the end of October or not. At this stage, we clear further work and analysis is required, but we're doing all the work that Andy's mentioned to make sure that we support the market.
I think part of that analysis also needs to be the impact on the authority if certain providers go under, because the impact on the authority is going to be immense and the cost of that. And so I think we need to do all we can to try and maintain what we've got. And we've done really well during COVID. And I think the messages with the independent sector and the partnership working has been great. So we need to maintain that to try and stabilise as much as possible in Portsmouth at least. So yeah, I thank you for the work you've done so far, and let's hope it is a little bit better out there than we hope it will be.
It's also worth adding to that that we're expecting to see a report from the Social Care Task Force. We're hoping that will be within this month, but they were also charged with looking nationally at the sustainability of the sector. So we may well see some national developments as well, and of course we'll brief as soon as we see those.
You're not going to hold your breath, though, are you?
I couldn't possibly comment.
I'll comment. No, Jeanette. No, I wouldn't hold my breath. I think I just on this particular point, and then I'll bring Graham and Matt in if they want to. But I do think that the ongoing uncertainty for care providers nationally and obviously in our particular case locally is of real concern. And I think that was really borne out in many ways by the because obviously it affected so many, but local individual care providers as well, was the discharge guidance. Because I think we were promised that, and it was 5 weeks between the date we were promised and the date we received it that we got it. And local authorities, care providers, everyone was absolutely, you know, chomping at the bit to get it and promised it and sick and tired of the wait. And I think when you get a combination of care providers and the LGA and local NHS all combining to say what is going on, where is this information, I think that really tells you something about how amiss the top of the Department of Health and Social Care has been with things like this. But in the end, I think everything we're doing is looking at the market as a whole, because we have that responsibility to do it. But more than that, we have that relationship with our care providers, which is so important. And you're quite right, Jeanette, if one of our care providers falls over, then the costs of providing something instead is almost certainly going to be more. And that's why it's so fraught, where we're trying to juggle this money which is being finite from governments, and there might be more to come that has got some strings attached or not, but we don't know, because there's no, as Andy said, there's no ongoing funding strategy, which again we've been waiting for 3.5 years for. Anyway, Graham or Matt? Matt, go ahead.
I appreciate probably don't want to go into this in too much detail in this meeting, but I just wanted the report raised some implications about potentially the financial position of the Health and Social Care Department in the council as a result of things like extra people needing ongoing support and the backlog. One of the earlier versions of the report, I think, talked about potential costs with clearing that backlog as part of the plan you're putting together to clear the backlog in work. Obviously, back in April, March, when we thought this wasn't predicted, more money was put into adult social care to try and remedy the shortfall that was already there, because it's obviously a very pressured department. They've had to do all this incredibly hard work through COVID. What is the financial position for the council looking like this year? Is this looking like it's going to push back and give us an even greater deficit this year, or has it been something you've been able to handle and the government funding has mostly kept up with, or are we looking at a bigger gap going into future years as a result of this outbreak?
Richard, do you want to?
Yeah, I'll try and answer some of that, but in terms of adult social care, then obviously there is a significant pressure coming through the system. It's still changing, so it's difficult to actually pinpoint and actually say what the forecast outturn for the financial year will be. But obviously the overall position of the council is that it's added an additional financial challenge, and the Section 151 officer is currently working on plans and has presented some information on that already to Cabinet and Council. So I wouldn't want to give an update on that at this point, because I think we need to leave that to that forum. But in terms of adult social care, we're now trying to work out what the financial position will be, the impact of this going forward, because we've had all these different temporary funding arrangements, and as we just talked about, the temporary funding support for clients with packages of care. And now that funding arrangement has changed from the 1st of September, we're now trying to work through all those clients to understand whether there's an ongoing financial burden for those packages of care on the City Council, whether some of those arrangements of care were temporarily higher than they will be going for on longer term basis, and also whether some of those clients are also self-funding. So there's a number of changing pieces in that position, and also we just talked about what financial support will continue to be required, if any, for this the care market, so, and sort of implications of such as the sort of social distancing requirements for respite care and the capacity that daycare providers can take. So all these things are having an impact on the financial position, and it's too early, I think, to say what the future position will be for next year and the ongoing years. And that's what we're trying to work through now as each of these pieces gets greater clarity. So I think we should be able to give a more of a detailed position later in the financial year as we start to see sort of the work that's being done further being rolled out, and a greater understanding on the sort of the wider COVID implications nationally, whether there is a second wave or and what impact that might have. So I think there's lots of work going on. There's definitely a financial challenge. The scale of it is still, I would say, unquantifiable at this stage for a longer term position.
Well, thank you.
Thanks, Matt. Graham, did you want to come in?
Yeah, just a bit of a follow-up really to what Matt was asking. At the bottom of 2.2, the last paragraph, we talk about the backlog. Obviously, we haven't been able to do things because of COVID.
You're on mute, Graham.
So I'll just go back and say, paragraph 2.2, the backlog, is it just a combination of work we weren't able to do because of COVID? Or is there also an increased demand for services as a result of COVID, or other factors that has caused that backlog and is likely to produce a problem with the financing? I would ask a question about finance in a moment, but I'll just stop there if I can on that one.
It's both. So we took it was an individual approach, I guess, during the higher incidence of COVID-19, in that some people didn't want us to visit. It was difficult to do some remote assessment work for quite a lot of people. So we do have a backlog there, most certainly. And of course, the scheme one that I referred to, the initially open-ended funding, or open-ended, maybe that's unfair, but the funding that didn't have a closure date on it, means that we didn't make assessments. People came straight out of hospital. There has been an increased demand. As Richard said, it's very much a settling picture, so it's really difficult to give you a precise focus around that, because what we see is, if you think of the graph with our normal demand and then peaking for those people that required care during COVID, and that sort of settles and flows depending. Some people come off of that who required care during COVID, and some people stay on that and they may come off later. So we've definitely seen an increase in demand, and we're also, interestingly enough, seeing an increase in demand at our front door. So people that are approaching the council for support, we're seeing far more people come to the council now, or to adult social care, now in the council, than we would have seen at this time last year. So it's a combination of those two things, essentially.
And just the recovery plan, just as a plan is in preparation, where will it come? Will it come here to be seen, or will it go to the cabinet, or do we not know yet?
What we've done at the moment is taken what we think is our best guess plan and focused on that with Councillor Winnington, with the portfolio holder. It very much depends where we attribute the resources to manage that plan to, as to whether that's taken more widely or whether that's decided by Councillor Winnington.
Thank you.
Thank you very much. And yeah, I think, and I'd like to thank Andy and Richard for for their contributions, and Andy for the report. I think it's a very wide-ranging situation, and going back to what I said earlier and what Andy's alluded to, and Richard, there's so many unknowables about this. One of the things I think that we're not going to know for months yet is about the long-term health impacts of people who've had COVID, because that's still not at all clear, and what impact that's going to have. Obviously, we've now got this new discharge guidance, and how that's going to work through in terms of, because it's still the discharge, so it's not the 3 hours anymore. It's still fast, and it's still different for us to be managing, and where the cost falls and everything. And I think there's so many unknowns, and going back to the finance point, the other thing is that that Richard alluded to, but perhaps didn't, is about looking at the whole of the council finance, where the funding that we have had from government, what it can be attributed within the council, because some of it will be attributed to adult social care, but others will be to other bits of the council of funding we can use, especially to do with lack of income, so where we've missed out on income. But I think the bottom line, answering Matt's question, was that the money we've got from government is by no means going to fill the void. So that we've talked about this at full council and in other places, that there is going to be a significant amount of financial gap between the money we've had from government and the money that we've lost either through having to spend out more or lost out on income. So that is a significant bit. How that falls in adult social care is not clear yet. And as Richard said as well, we're doing these appraisals of people to try and actually get a true figure rather than entirely speculative at the moment, because work that we couldn't do because we couldn't do effectively, we couldn't go out and see people, hasn't been done because we couldn't get into their homes, and that's one of the big issues that now we can do that. We can actually do true assessments of their needs, but it is it's such a moving feast, and I think one of the things that's come out of this the pandemic is I've never seen finances move and shift as much as this has, because you just don't know what's going on, and you don't know where funding's coming from, and you don't know exactly, you can't pin things down because things then change again. So but thanks very much for the report, and thanks everyone for your attendance today. Obviously a reminder that our briefing, our spokesperson's briefing, is on Thursday at 12, and just to let you know, as Graham's brought up, and there might be an issue going forward on that time. So what I'll do, come the end of the month, still keep that as a fortnightly briefing, but I will ask you all if that's a good time, or if there's other times that are better for you within the week that we can sort of fit in to make sure that all of us can attend as much as possible. So, but thank you very much for everyone today, and obviously happy to note that report, and I'll see you all again soon.
Okay, thanks very much. Thank you.
Stop the live stream and let you know when it's finished.
Okay, thank you.
Right. Oh, if only Peter stopped it.
Okay.
He stopped it.
All right.
Thank you very much.
See you later.
See you later. Bye now.